أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم نحمده ونصلي على رسوله الكريم أما بعد فأعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم. Hello my dear students, how are you? How is your life going on? Enjoying and relaxing? I hope that all of you will be doing good and will be in good shape of health. I always pray that Allahumma rfa'anna al-aba'a wal-waba'a. ऐ मेरे प्यारे अल्लाह हमसे मुसीबत और वबाई बीमारियों को हटा दीजिए। हमारी ये दुआ उस वक्त तक है जब तक हमसे ये वबा और मुसीबत कोरोना की शक्ल में हमसे दूर ना हो जाए। In past few lectures, I have discussed various conditions of small intestine, then going through peritoneum, retroperitoneum, then mentum and mesentery. My today lecture will be an approach to the acute abdomen. A different abdominal condition which can present to a physician with acute conditions. So, do you agree with this picture? Sometimes some uninterested students can show their presence like this, but I'm sure that none of you is behaving like this. Okay. So today topic for our discussion is acute abdomen, and evaluation of patient with acute abdomen is one of the most challenging aspect of surgical emergency. What do you think? Do you agree with this sentence? Why I have used this? Because abdomen or peritoneal cavity is called as black hole of medicine. So acute abdomen is a challenge to surgeon and physicians. It is the most common cause of surgical emergency or admissions. It encompasses various conditions ranging from trivial to life-threatening conditions, and its clinical course can vary from minutes to hours and also sometimes to weeks. And it can be an acute exacerbation of a chronic problem. With this preamble, our learning objectives for today's discussion will be: what is the definition of acute abdomen? What is the symptomatology of acute abdomen? How can we assess regarding history and examination for acute abdomen? How can we group various signs and symptoms? For example, differential diagnosis for acute abdomen. What are the various investigations required for the acute abdomen? And lastly, what will be the management for these acute abdominal conditions? So first learning objective is: what is definition of acute abdomen? Can anybody recall? Okay, take a minute. Okay, so it is defined as any clinical situation in which an acute change in the condition of the intra-abdominal organs, usually related to inflammation or infection, demands immediately and accurate diagnosis. So this is a definition for acute abdomen. What is symptomatology of this acute abdomen? The primary symptom of the acute abdomen is, tell me, abdominal pain. And this abdominal pain is not related to trauma. So excluding trauma, all those conditions which cause abdominal pain will be labeled as acute abdomen. So our third learning objective is based on our assessment, which is comprising of history and examination to arrive at a specific diagnosis. So in history, we can say that what are the types of abdominal pain? Can you tell me types of abdominal pain? Acute abdominal pain? Yeah, this is visceral pain. Second is parietal pain, and third is rapid pain. Okay, can you tell me what is visceral pain? You all know? Yes. It is due to stretching of the fibers innervating the walls of the hollow or solid organs. It occurs early and it is usually poorly localized. And it can be due to early ischemia or inflammation of the involved organ. Second type of pain is parietal pain. What is the parietal pain? It is caused by irritation of parietal peritoneum fibers related to involved organ, and it usually occurs late but it is better localized, and it can be localized to a dermatome superficial to the site of painful stimulus. Our third type of pain is rapid pain. Can you describe rapid pain? Yeah, it is pain felt at a site away from the pathological organ. For example, pain of acute cholecystitis is usually referred at the tip of the shoulder. But here pain is usually ipsilateral to the involved organ and is felt midline if the pathology is midline. This pattern is based on the developmental embryology of the involved organ. So there are three types of pain. One is visceral pain, second is parietal pain, third is rapid pain. Then comes the classification of acute abdomen. What are those conditions? We can again divide it into three categories. Number one category is intra-abdominal conditions. The pain arising from within the abdominal cavity or retroperitoneum, and it involves gastrointestinal tract like appendicitis, diverticulitis, etc., etc. Then genitourinary systems, which involves renal colic. Third system is gynecological system, which includes acute pelvic inflammatory disease or pregnancy. Then vascular system, which includes acute abdominal aorta condition and mesenteric ischemia, acute abdominal aneurysmal conditions. Third type of classification is based on extra-abdominal, which is less common, and the causes for pain which is felt at abdomen may be from cardiopulmonary system. For example, acute myocardial infarction, you know that pain can be felt in the epigastric region. In the abdominal wall, herpes zoster or hernia can cause pain, while toxic metabolic condition like diabetic ketoacidosis, lead poisoning, can also present as acute abdomen. Then neurogenic pain, for example, herpes zoster pain, and various psychic conditions like anxiety or depression. The patient with these conditions can present as acute abdomen. And the third variety is of non-specific abdominal pain, which is not very well explained or not described. So in history, what will you elaborate various points? You will look for location, the quality of the pain, severity of the pain, regarding its onset and duration of the pain, what are the aggravating and alleviating factors, and what are the associated gastrointestinal symptoms like nausea, vomiting, diarrhea. Is this abdominal pain associated with other genitourinary symptoms, and whether this is associated with vascular symptoms like atrial fibrillation, acute myocardial infarction symptoms, or abdominal aortic aneurysmal pain. Some conditions overlap in various systems like nausea and vomiting in both gastrointestinal and genitourinary pathologies. So you also inquire in past medical history, what is the recent and current medications, is there any history of past hospitalization, whether that patient has past history of any surgery, is there any chronic comorbid disease, what is the social history of the patient, and what is the occupation. For example, toxic exposure like carbon monoxide or lead poisoning can lead you to the diagnosis of acute abdomen. Second part of our third learning objective is assessment, and this needs examination. Before going on that examination, I will discuss with you the abdominal topography. You know, for examination, abdomen is usually divided into 4 regions or 9 regions. 4 regions, for example, right upper quadrant, left upper quadrant, right lower quadrant, and left lower quadrant, with 2 lines, one vertical line in the midline and one horizontal line at the level of umbilicus. While the second criteria for dividing abdomen into region is drawing 2 vertical lines and 2 horizontal lines. 2 vertical lines at the level of the mid-clavicular line joining the mid-inguinal ligament point, and 2 horizontal line, upper one at the level of transpyloric plane at the tip of the 9th costal cartilage, and the lower horizontal line joining 2 interior iliac spine. Like this. On physical examination of the abdomen, note that patient general appearance, realize that the intensity of the abdominal pain may have no relationship to the severity of illness. One of the initial steps for the physical examination should be obtaining and interpreting obtain vitals, and you should remember that patients with visceral pain are unable to lie still, while patients with peritonitis will like to stay immobile. These are the tips and tricks in the physical examination of the abdomen. While the common errors in physical examination of the abdomen are that you focus only on the abdomen and begin with palpation prior to inspection, auscultation, and percussion, and you not proceed with asking the patient to localize the pain, and therefore beginning palpation of the affected area first, which can exacerbate the pain and thus precluding complete examination of the abdomen. And fourth error is that you skip the rectal, pelvic, and groin examination and putting too much weight on the absence of rebound tenderness to rule out peritonitis. And lastly, you also forget to consider mesenteric ischemia when there is pain out of proportion to clinical examination. While doing abdominal examination, it cannot be overemphasized that a thorough physical examination from head to toe is important to help in arriving at a comprehensive differential diagnosis list. For example, you should also look for jaundice because the presence of jaundice may add consideration of a biliary or hepatic etiology. You should also look for counting the pulse because irregular heartbeat can denote to atrial fibrillation, which can clinch on the diagnosis of mesenteric ischemia causing acute abdomen. And then there are various skin lesions like pyoderma gangrenosum, which is associated with ischemic bowel disease. Obtaining these three learning objectives, our fourth learning objective is grouping our signs and symptoms which we have obtained in our history and physical examination to make a differential diagnosis. To get this, let's solve few small clinical scenarios to enhance our understanding of acute abdominal pain. I will show you various short clinical scenario and will try to explain to you and will take your answer to those clinical scenarios. So our exercise number 1 is you have come across a patient of acute abdomen with severe central abdominal pain with shock and no peritoneal signs. So what conditions comes into your mind? Like this. So in this acute pancreatitis with pain rating to back will be this clinical scenario will fit into acute pancreatitis. Okay. And it will also radiate to the back. So this comes in the intra-abdominal causes. So with this scenario, what are the other conditions? This is intra-abdominal causes. What are the other causes? Other causes are rupture abdominal aortic aneurysm. Here there will be a pulsatile mass at the same level, and mind you that it needs a stat surgery in these conditions. This is our exercise number 2 with severe central abdominal pain, having shock and no localized peritoneal signs. Our exercise number 3 is severe central abdominal pain with shock and no localized peritoneal signs. We have discussed two conditions, acute pancreatitis, ruptured abdominal aneurysm. What is the third one? This is associated with hemoperitoneum. What is this? This also demands stat surgery. And condition for these are spontaneous rupture of spleen, splenic artery aneurysm. Here pain also radiates to the left shoulder like this. Central abdominal pain and the pain at the tip of the left shoulder. This is called care sign. Our exercise number 4 is again central severe abdominal pain with shock and low localized peritoneal sign. Again the pain is at the lower bottom and with shock and no localized peritoneal sign. The last right is ruptured ectopic pregnancy. Exercise number 5 is again with severe central abdominal pain. After elaborating all these intra-abdominal conditions, can you tell me some extra-abdominal causes? Yes, it is acute myocardial infarction with cardiogenic shock. Exercise number 6 is comprising of severe abdominal pain with diffuse peritoneal signs like this. Diffuse peritoneal signs. So, can you tell me the conditions which can present like this? Yes, it is perforated viscous usually. And what are the conditions for perforation of a viscous? This also needs a urgent surgery, and the conditions are gastric or duodenal ulcers, perforation of the gallbladder, complication of small and large bowel obstructions with maximal distension leading to perforation at the level of cecum, necrotic bowel due to mesenteric ischemia or strangulated hernia. Proceeding next to our exercise number 7, again with severe central abdominal pain with associated signs. Previous one were the intra-abdominal causes like intestinal colic, early appendicitis, early mild pancreatitis, early mesenteric thrombosis. These can present with severe central abdominal pain in their early stage without associated signs. Our exercise number 8 of acute abdomen is severe central abdominal pain without associated signs. Exercise number 7 were condition which arises from the intra-abdominal viscera. Then there are extra-abdominal causes. What are those? Can you describe? Yes, these are extra-abdominal causes like herpes zoster. It will be manifested with acute abdomen associated with rash in the dermatome distribution of involved nerve. Then glaucoma also present with acute abdomen, and third variety is tabes dorsalis, but it is rare in nature. Exercise number 1 is again severe central abdominal pain with distension but no vomiting and peritoneal signs. So distension with central abdominal pain. Can you tell me the condition which fits into this scenario? These are intra-abdominal causes like large bowel obstruction, while ileocecal valve is competent here, like sigmoid diverticular strictures, inflammation or cancer of sigmoid colon, volvulus of large gut, hernias, various abdominal conditions. Exercise 10, again severe central abdominal pain with a distension but no vomiting and peritoneal sign. And I'm asking about the extra abdominal causes. What are those? This like uremia. And the 11th exercise is severe central abdominal pain with vomiting, distension and no peritoneal sign. This is the easiest one. We have discussed it in our previous lecture. Yes, you know better. These are cases of small bowel obstruction, which will be having bilious vomiting in case of proximal obstruction, while fecolate vomiting in distal small bowel obstruction. Then there is third variety, which is called gastric outlet obstruction, where there will be no bilious vomiting, only undigested food particles will be present in the vomitus. Exercise number 12 is severe abdominal pain with localized peritoneal signs. For example, in the right upper quadrant. Look at this. There is also a pain in the right tip of the shoulder, and patient is also feeling pain at the back of right hypochondria. And what are the conditions which present like this? Yes, it is acute cholecystitis, pain referred to the back. Again, exercise number 13 is comprising of severe central abdominal pain with localized peritoneal signs in the right upper quadrant. One condition is acute cholecystitis, but what are the other conditions? Tell me here. Hepatic etiology like abscess, hydrated cyst, hepatitis, retrocecal appendicitis. These also present like this. Then exercise number 14 is severe central abdominal pain with localized peritoneal signs in the epigastrium or right upper quadrant. We have discussed other condition, and here it is associated with pain also in the right iliac fossa. What are those conditions? This is leaking duodenal ulcer. The patient will be having pain initially in the epigastrium, which later on the pain will be also felt in the right iliac fossa due to the perforation of the ulcer and drainage of the bile into the right iliac fossa. Then exercise number 15 with similar scenario, localized peritoneal signs in the right upper quadrant, but here pain is also radiating to the groin. And what is that condition? You know, that is pyelonephritis or pain condition involving the right kidney. For example, pyelonephritis, stones. And exercise number 16 is same scenarios and severe abdominal pain with localized peritoneal signs, right upper quadrant. Previous one were the intra-abdominal causes, and can you tell me what are the extra-abdominal causes? Yes, pain at the originating from the base of the lungs like lobar pneumonia. And the exercise number 17 is the common one, that is severe abdominal pain with localized peritoneal signs. For example, right lower quadrant vein, and this is the most common scenario of appendicitis. Pain initially will be felt at the periumbilical region at its onset, and later on it will shift to the right lower quadrant. Exercise number 18 is severe abdominal pain with localized peritoneal signs in the right lower quadrant. So what are the other conditions apart from appendicitis? Yes, these are leaking jejunal ulcer, terminal ileitis, Meckel's diverticulitis, right-sided diverticulitis, tuberculum involving the cecum, mesenteric adenitis. This is usually in the children. And retained testes or right testicular torsions, and in the urinary systems like urethral stones or pyelonephritis. Then Schwarz abscess can also present with acute abdomen in the right lower quadrant. Then the exercise number 19 is of severe abdominal pain with localized peritoneal signs in the left upper quadrant. Can you tell me those conditions which can present like this? Yes, this is pancreatitis, most common cause. What are the other causes? Perforated gastric ulcer, localized by adhesions, splenic artery, splenic injury or splenic infarct can present as pain in the left upper quadrant. Then subphrenic abscess on the left side can also present like this. Jejunal diverticulitis can also present with severe abdominal pain with pain localized into the left upper quadrant. Then pyelonephritis involving the left kidney. Exercise number 20 is again with severe abdominal pain with a localized peritoneal signs, for example, left lower quadrant like this. What are the conditions? This is diverticulitis of sigmoid colon and left colon. It can be also due to colon cancer with the surrounding inflammation. Then it can also be a case of upper extension of pelvic abscess. Then it can also be a case of ischemic bowel disease with pyelonephritis. Exercise number 21 is severe abdominal pain with localized peritoneal signs in hypogastric or suprapubic region like this. This can be a case of perforated diverticulitis or appendicitis and with pelvic position of appendix in urinary tract like ureteral stones or lower ureter. Bladder distension, cystitis can present like this. So exercise number 20 again with pain in hypogastric and suprapubic regions like this. What are the other conditions? These are gynecological or obstetric condition can present like with acute abdomen, for example, with uterine colic, dysmenorrhea, with torsion or ruptured ovarian cyst, and it can also be a case of ectopic pregnancy with threatened abortion. Thank you very much. I hope that with this exercise, having going through these various scenarios, you will be able to diagnose a case of acute abdomen. With this, I will end my topic with approach to acute abdomen. Allah Hafiz, stay blessed. And you know, a good surgeon has an eagle's eye, a lion's heart, and a lady hand. And